saga. I'll be talking about a complication which is often seen after LASIK more often, although has been reported after SMILE as well. And it is epithelial ingrowth, which actually occurs because the epithelial cells invade the space between the flap and the stromal bed. So the it lines the stromal surface, it lines the undersurface of flap, it can line the flap hinge, it can line the flap edge, and it can be small transparent epithelial pearls to translucent clumps to opaque sheets. So it depends on the severity. It can have variable severity. There are certain factors that are related to it. There should be a source of surface epithelium, there should be a surface deficit, abrasion, or defect, and there should be a space to grow. So the space to grow means that the flap adhesion is not very good. And that is why it happens. And it ranges from 0 to 3.9% in primary treatment to 10 to 20% in retreatment, because you have to lift the flap and there's a lot of manipulation, and then the flap adhesion may not be that good. You can implant an epithelium on the stromal surface. And when you examine these patients, when you do fluorescein staining, you get a small area of stain from where the epithelium is entering. So that shows that the flap adhesion is not very good in that area, and that's how epithelium has migrated inside. Now, in majority of patients, you will see that there will be a few, transparent clumps, transparent cells in the periphery, and the patients are asymptomatic initially, and they have very subtle findings. But it may be progressive, and if it's progressive, then it can lead to clumps, it can lift the flap, it can cause astigmatism, it can cause flap irregularity, flap melting, and all these things can be detected by serial photographs and topography. As I said, there are certain risk factors. There should be an epithelial defect at the time or soon after surgery. Mostly you see these things seen if the patient is predisposed, like having epithelial basement membrane dystrophy. In such cases, there can be epithelial defect, and the patient can have epithelial ingrowth at the time of epithelial healing. Hyperopic LASIK correction, because the laser ablation is done in the periphery, and that's why the flap adhesion is not very good and in the periphery, and sometimes you can have epithelial ingrowth because of that. Repeat LASIK surgery, because if you lift the flap, a lot of manipulation, you can implant an epithelium in the undersurface of the flap on the stromal surface, and then there's proliferation, and that can lead to it. Then that leads to flap irregularity, and it is also seen in some diabetics, of course, because of the poor epithelial adhesion on the ocular surface. As I said, it is more often seen with the hyperopic LASIK. This was one study which it was a retrospective study done on 1,000 patients who underwent microkeratome LASIK. It included both myopic and hyperopic, and they found out that the total incidence of epithelial ingrowth was 4.7%. After primary treatment, the total incidence was 3.9%, and incidence after enhancement was 12.8%. The incidence was 3% in myopic and 23% in hyperopic group. As far as myopic is concerned, for the primary treatment had 3% and hyperopic had 17%, and after enhancement it was 7% in myopic and 43% in hyperopic. So as you can see here, it's more often seen with hyperopic because of the fact that in the periphery the laser ablation is done, and that's why the flap adhesion may not be as good as we see in the myopic LASIK. Mashat has given the grading system of epithelial ingrowth, which divides epithelial ingrowth into 3 grades, grade 1, 2, and 3. In grade 1, you have ingrowth of less than 2 millimeters from the edge of the flap. They are transparent cells, and there's a clear demarcation line between the advancing cells, and between the cells and the area where it is not. And in grade 2, you have thicker ingrowth up to 2 millimeters from the flap edge. It is, but there's no demarcation, and you can see these are translucent cells, and then gradually they are progressive. So as they will progress, they will require some treatment. And in grade 3, the ingrowth is more than 2 millimeters, and it can lead to flap elevation. There can be flap melting, and it requires an urgent treatment. As I said, there can be implantation of epithelial cells by microkeratome blade or even by cannula during irrigation of flap. And post-operatively, what happens is that there can be some abrasion, and then there's epithelial healing, and the flap adhesion is not strong, and the epithelium goes under the flap, and that is how it proliferates. When you do a relifting of flap for retreatment, then you can introduce epithelial cells, and if there's a trauma to the flap, sometimes, as in this case, this patient came to me after a week of trauma. The patient suffered trauma, and then after that came with a complaint of visual problems. And as you can see here, there's flap stria, there was flap dislocation as well, and so in this case, the flap was lifted and the epithelium was removed. It was scraped off. Then ironing was done in order to, get rid of the flap stria, and the flap was reposited. And then the superficial epithelium in the area of, coarse flap stria was also removed. So the epithelium debridement was done, and then the flap was swelled. And then a bandage contact lens was placed. And of course, after removing the epithelium from the undersurface, mitomycin C was placed 0.02% for 1 minute. So this is the post-operative picture. You can see there's no flap stria, there's no epithelial ingrowth. So this is what we do. We lift the flap and scrape the epithelium. But there are studies which have shown that they don't scrape the epithelium, they do excimer laser PTK. For that, or even partial removal of epithelium by manual scraping, and then excimer laser PTK is done, and then mitomycin C is used 0.02% for 1 minute. The risk is that there can be recurrence of epithelial ingrowth, so you have to be really very careful. Now, what happens that there is a general teaching that if the epithelial ingrowth is in the periphery, you don't have to treat, you have to follow up, and that is what was being done in this case. The epithelial ingrowth was in the periphery only, but then gradually there were clump formation, and then it lifted the flap, and then there was flap melting. If there is a flap melting like this, then there are two options. Either you amputate the flap after, of course, removing the epithelial ingrowth. You amputate the flap because you can't leave the same flap because there will be recurrence of epithelial ingrowth. And if you have a facility of a donor lenticule, then you can also do a superficial anterior laminar keratoplasty. So this patient came to us, and then the flap amputation was done. Epithelial growth was removed, mitomycin C was applied, and then a similar thickness of donor lenticule was placed. The thickness was noted by use of ASOCT and also by the record of the patient, what plastic flap thickness was used. The same thickness donor lenticule was placed, and so this is sutureless superficial anterior laminar keratoplasty for flap melting. And once the donor lenticule was placed, then you put a little bit of fibrin glue after drying the edges nicely so that the donor lenticule adheres well, and then you put fibrin glue at the edge, and then a bandage contact lens is placed over it. Then there are studies wherein people have done flap amputation, and then they have done PTK, and they have used mitomycin C for severe ingrowth. This was one case reported by Kimionis group, and they did the flap amputation, then did PTK and used mitomycin C for 2 minutes. And then 6 months later, the uncorrected visual acuity was 20/40, and best corrected was 20/32. And as topographic astigmatism decreased from 3.24 to 1 diopters. Epithelial ingrowth has also been reported after a smile, and if there is quite significant epithelial ingrowth, then in that case you may have to create a flap, convert this pocket into a flap, lift it, and remove the epithelium, use mitomycin C, and then reposit the flap. So in conclusion, LASIK, of course, is a safe surgery, but complications do occur. And one of these is epithelial ingrowth, which happens more often with microkeratome LASIK, but may occur with femtosecond as well. And if there is an epithelial ingrowth, it is very essential to follow up the patient very regularly. Even if it's in the periphery, you can have clumps in the periphery that can cause astigmatism, that can lift the flap, that can cause flap melting. So meticulous follow-up of these patients is very essential, and when required, appropriate and prompt management should be done. Thank you very much for your patient listening.